Dear audience, in the next few minutes, I will introduce the one-year progress of our research about optimizing the time of cord clamping and the dosage of caffeine among preterm infants. My name is Gréta. Currently, I'm a first-year PhD student and I'm working at Heim National Pediatric Institute. My vision is to improve the quality of life and extend the life expectancy of newborns. To achieve that, optimizing the time of cord clamping and the dosage of caffeine among preterms are my missions. Now let me introduce our two ongoing projects and specific goals to complete these missions. Our first project is about investigating the outcomes of neonatal resuscitation with and without intact cord. According to the guidelines based on the ICOR recommendations, for those preterm and term infants who do not require resuscitation at birth, delayed cord clamping is or may be reasonable. Delayed cord clamping is associated with significant neonatal benefits, such as improved translational circulation, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. Most newborns live spontaneously after birth, but around 15% require some degree of active resuscitation. The need is inversely related to the gestational age, so for example, for the very preterm infants, it is approximately 85%. Unfortunately, for these preterm and term infants, we have insufficient evidence on the optimal time of cord clamping. So our aim is to determine whether intact cord provides physiological, neonatal mortality and morbidity benefits for infants requiring resuscitation at birth. During our research, we examined how starting resuscitation before and after cord clamping affect the neonatal outcomes. We hypothesized that starting resuscitation with intact cord decreases the incidence of neonatal mortality and morbidity and increases oxygen saturation level at 5 and 10 minutes after birth. We conducted a systematic search on 19th of November last year with this search key of 2 domains. It resulted around 16,000 hits, and after the selection processes, we had 14 eligible articles. With reference checking, we found one further eligible study. However, in the meta-analysis, we decided to include only the RCTs. Now let me show you our main results. On this first forest plot, you can see the result for one of the hardest outcomes, the in-hospital mortality. A total of 5 studies were selected for the analysis, covering around 600 patients. The overall risk ratio is 0.89, which means there is an 11% higher risk for in-hospital mortality in the cord clamping prior to resuscitation group. Although this result is clinically relevant, it did not reach the significance level, the event numbers are low, and the population is heterogeneous. On the next 5 forest plots, I will show the results for different early complications of the prematurity. The total sample size was around 300 patients in all outcomes. The overall risk ratio for all grades of intraventricular hemorrhage was 1.25, while for the severe IVH is 0.96. These results suggest that, meanwhile, the risk for all grades of IVH is 1.25 times higher in the intact cord resuscitation group. Fortunately, the risk for severe IVH did not show difference between the groups. The next one is the necrotizing enterocolitis higher than grade 2. The overall risk ratio is 2.05, so this means there is a 2 times higher risk of this early complication in the intact cord resuscitation group. If we examined only the studies where they performed delayed cord clamping in the control group and not early cord clamping, we see that the risk is even higher. Regarding the analysis of retinopathy of prematurity requiring treatment, we see that there is a 1.6 times higher risk of this early complication in the intact cord resuscitation group. To summarize the results of these early complications of the prematurity, we can say that these results are clinically relevant. However, they did not reach the significance level and the event numbers are low. On this last forest plot, you can see the analysis for oxygen saturation level at 5 and 10 minutes after birth. The mean differences suggest that in the intact cord resuscitation group, the mean oxygen saturation level was higher with 6.67% at 5 minutes and with 2.87% at 10 minutes after birth than in the control group. Considering our research, we have strengths and limitations as well. Former ones are those we included only RCTs, examined preterms and terms also. We have 17 analyzed outcomes and detailed subgroup analysis. Unfortunately, the small sample sizes and even numbers, the different definitions of outcomes, the heterogeneous protocol of intervention, and the use of various resuscitation platforms challenges the generalizability of our findings. Summarizing our results, due to the observed improvement in the delivery of oxygenation for the population of term infants, it appears that recommending intact resuscitation may be warranted. However, for the population of preterm infants, intact resuscitation should be applied carefully. We recommend to carrying out this practice only in specialized centers with appropriate protocols and expertise due to the potential for complications. Unfortunately, there is still no clear evidence for optimal cord management during neonatal resuscitation. Therefore, we recommend to have high-quality RCTs with larger sample sizes and standardized protocols. On this post, you can see the progress of our manuscript writing. We are planning to send it to internal review this week. In the last couple of minutes, I would like to say some words about our second project as well, which is about comparing the effects of different dosages of caffeine on neonatal mortality and morbidity. We are using the method of systematic review and meta-analysis for this one too. Caffeine therapy is widely used among preterm infants as it is effective in reducing apnea of the prematurity, need for and duration of mechanical ventilation, and decreases the incidence of bronchopulmonary dysplasia. Due to the possibility of serious neurological side effects, the CAP trial was conducted. They found that there is an improvement in the rate of survival without neurodevelopmental disability in long-term follow-up in infants who received caffeine therapy. The commonly prescribed dose is 5 mg per kilogram per day caffeine citrate, but unfortunately there is still uncertainty regarding the optimal dose to achieve effectiveness by minimizing potential side effects. In the available research papers, there is a wide range of the used caffeine maintenance doses from 3 to 20 mg per kilogram per day, so our aim is to compare the effectiveness and side effects of different maintenance doses of caffeine therapy among preterm infants. So our clinical question is, what is the optimal maintenance doses of caffeine citrate for extremely and very preterm infants? We hypothesize that the administration of higher dose than the commonly used 5 mg per kilogram per day caffeine citrate improves the survival and decreases morbidity without worsening side effects. On this slide, you can see a short summary of my previously introduced projects. The first one was about the optimal cord management during neonatal resuscitation, and the second one about the optimal caffeine maintenance doses among preterm infants. We are planning to submit the first one in September and the second one in December. And I would like to finish my presentation with one of my favorite quotes by Ray George, which is, "There are two types of people who will tell you that you cannot make a difference in this world. Those who are afraid to try and those who are afraid you will succeed." Thank you for your attention.
You mentioned about which cord clamping methodology should be used when the baby doesn't need resuscitation. What's the cord clamping method if the baby should be used if the baby is needing resuscitation or higher level of stabilization?
Thank you for your question. Yes, I already mentioned, but I didn't say specifically. But according to the guidelines based on the ICO recommendation, they recommend a 60-second delay in the cord clamping if the baby doesn't need any immediate resuscitation. But in cases when they need immediate resuscitation or stabilization steps, then they recommend to do early cord clamping because they need the immediate stabilization steps and then start the initial interventions. But the guidelines say if there is an opportunity for adequate thermal care and to start the initial resuscitation interventions with the intus cord without harming the baby, then they can delay the cord clamping.
Thank you for your presentation. I'd like to ask you a question regarding to your second project. Maybe I just missed the information that the higher dose of caffeine could have any serious side effects, the use of higher caffeine?
Yes, thank you for your question. They thought that the higher caffeine dose can cause like neurological side effects. That's why that CAP trial was conducted. And also there are other side effects that can happen. For example, the necrotizing enterocolitis, the feeding intolerance, bloating, tachycardia. They think these can happen. That's why there are studies for that. For example, for the neurological one, the CAP trial, and they found that there is no.
As I know, there are 2 ways of administration of the caffeine. And are you planning to investigate separately these 2 ways of administration in the second project?
Thank you very much for your question. Yes, we are planning to do subgroup analysis based on those if we can, based on the found included studies, because the pharmacokinetics are different for those.
We all know that we should do the maintenance dose for caffeine once a day. Okay, but our nurses like it just divide, I don't know, Q12 or Q8. And did you have any data about dividing the maintenance dose for caffeine?
We haven't started the second project yet, so
in the literature, is there any data for dividing the dose or no?
I hope there is, but I'm not sure.
Okay, thank you.